Our next speaker is John Hartberg. He will be speaking on ketamine's therapeutic potential, practical considerations for clinical use. John Hartberg is a medical student at the University of Queensland in Brisbane, Australia, where he is conducting research at a psychiatric practice using oral ketamine for the treatment-resistant depression and PTSD. One second. Can you... Okay, one last sentence of his bio now that it's a little bit more quiet. John previously served as a study coordinator for the MAPS-sponsored MDMA therapy study in Marin County and worked with MAPS to compile data for ibogaine and MDMA studies. Please welcome to the stage John Hartberg.
Cool. Oh, great. All right. Is that on? Can you hear me? Yeah, cool. Well, thanks for that panel. That was pretty incredible. And I'm sorry to cut off all the people that had questions. I know everyone's tight for time here. My body became lighter, and the colors became clearer. Before that moment, I didn't know what was causing the anxiety. It was the first time that I was able to turn the volume down and to finally see things clearly. Now, that is one man's personal experience at an otherwise nondescript suburban psychiatric practice with what has become in a few short years the only widely available psychedelic therapy modality that is legal in the country. Now, ketamine was approved by the FDA in 1970 for anesthesia, but only within the last few years have we seen an interest in ketamine for psychotherapeutic potential. In fact, 3/4 of scholarly papers involving ketamine and depression have been published within the last 7 years. So the question is, why the sudden interest? Well, first and foremost, there's a desperate need for more effective treatment of depression in the most severely ill patients, the treatment-resistant depression. And I think it's also got something to do with something we've been talking a lot about this week, which is a shifting culture, a culture that is perhaps more open to the idea that altered states of awareness can be a beneficial part of the normal human experience. Now, there are currently dozens of ketamine clinics operating across the country. This is just a handful here that I pulled up. And there's probably even more ketamine clinics or more ketamine use being used on a case-by-case basis by curious practitioners. And despite this widespread use, there's, at this point, quite little consensus on its best practices. Now, ketamine can be administered in any number of routes, and as we heard during the panel, the most popular route of administration is an NIMH protocol calling for 0.5 milligrams per kilogram delivered over 40 minutes. But of course, as we also heard, that was a largely arbitrary choice, and so recently there's been more interest in the non-parenteral routes of ketamine administration, namely sublingual, an intranasal spray, and oral ketamine. And so at the private clinic in Brisbane, Australia, that I've been compiling data at, Dr. Angelo DeJonis and his colleagues are utilizing the oral form of ketamine at a sub-psychedelic, more or less threshold dose, and using that in conjunction with psychotherapy for treatment-resistant depression. And so today I'm going to tell you a little bit about what he's been doing at that clinic and some of the advantages and disadvantages of oral ketamine, some of the results of a retrospective chart summary that we've been conducting, and last, why oral ketamine might be worth considering. But before that, before discussing ketamine use, I just want to say that we talked a little bit or heard a little bit about ketamine's bad rap. The desire to rebrand it, and I think a lot of that stigma is unwarranted in this medical application because these are low doses that are being given, and they're among the most, or used among the most severely ill patients, especially those with treatment-resistant depression. So, these aren't patients coming to the clinic looking for easy access to a party drug, and they're not even explorers of consciousness or something along those lines. They're severely ill patients. Now, one of the difficulties of orally administered ketamine is proper dosing. So with IV ketamine, you have 100% bioavailability. You have a much more predictable response in that sense than you would giving ketamine from an oral route. With an oral route, you actually have something along the lines of a 20% bioavailability, and that's like with a plus or minus 5 or 10% window on either side. In addition, there's differences in the mechanics of somebody's GI system, so whether or not they had previous gastric bypass surgery, which we've had at the clinic a number of times. And so knowing the difficulties of dosing, well, why would you want to do oral ketamine in the first place? And the reason is that it centers around accessibility and friendliness to the patient. So most people don't like needles, and if there's a way to administer a drug orally without having to poke around in somebody's arm, they generally prefer that. And the second reason is the importance of sustaining the remission of depression in patients. Now, ketamine is a rapidly acting antidepressant, but that's not necessarily the same as having a sustained effect. And to be effective in the long term, it seems that repeated administration over the course of treatment is needed in many patients. So this is a particular study from Mount Sinai where they followed the NIMH protocol of 0.5 milligrams per kilogram IV infusion, and there were significant reductions in depressive symptoms. But then they looked at the period of time following the 6th infusion, and at 1 month out, 70% of patients had already relapsed. And so if you can monitor these patients for a longer period of time and continue to give the ones who need it more ketamine therapy, then that can be beneficial. Now, also to note that in 30% of patients, up to almost 3 months out, they had no relapse. And so this points to the wide variability of response to ketamine that many patients have. So this is the general procedure that we use at the clinic for oral ketamine administration. I probably should have included a little bit more detail on this slide, and also ignore that third bullet point. So that slipped in there by mistake, and I'll explain that in a little bit. So the most important part of oral ketamine is an individualized titration method, which begins at 0.5 milligrams per kilogram, which is quite low for an oral dose. And that dose is escalated over the course of several weeks until the patient reaches what amounts to the minimum psychoactive level, the sort of a threshold level. I don't want to say it's a ketamine microdose. It's a bit more than that. Often patients compare it to a glass of wine. Although one patient 2 weeks ago said it felt like he had a six-pack. So, it's hard to tell exactly how people will react to that. And then once that threshold is reached, then that level that they reach after titration is quite dynamic. So that can go up or down from week to week as they revisit the clinic and sort of respond or verbalize their response to how they felt to it. The ketamine is now in the form of lozenges, but previously it was liquid. And so what patients would do would be come into the clinic, and in most cases they'd actually have a psychotherapy session first. So prior to prior to the administration of ketamine, not actually what might be called ketamine-assisted psychotherapy. And then following the psychotherapy session, they would drink liquid ketamine with like an Australian version of Kool-Aid and sit in the dark room until the effects peaked. They tend to peak with oral ketamine on an empty stomach at something like 20 to 30 minutes. And so at about an hour, they're able to leave the clinic with the assistance of a loved one or a friend. Now, the protocol has switched since the beginning of the year, and so what Dr. Angelo has been doing is instead of giving oral ketamine in the clinic, the clinic time is used instead for therapy. And the patients are now sent home with generally a 2 to 4 week supply of ketamine lozenges. And those ketamine lozenges are taken 2 to 4 times per week, depending on what the patient needs. And that actually enables a higher frequency of ketamine administration, but a lower dose. And so patients are actually able to decrease the amount of ketamine that they were taking prior to, or when it was in liquid form. During this time, patients are taking their regular medication, or they're able to. Now, most patients are able to stop taking regular antidepressants like SSRIs and SNRIs. But the one thing that patients do tend to have is something like alprazolam for breakthrough bouts of anxiety. So instead of taking more ketamine for those sort of breakthrough events, they'll take a fast-acting anti-anxiolytic. So one of the big questions that comes up is safety. And of course, with the new protocol especially, is it okay to send patients home with a 2-week supply of ketamine? And as Dr. Wilson touched on earlier, it would be notoriously difficult to try to abuse those lozenges. You could perhaps swallow all of them at once, but that would still be well under the amount that you would use for anesthesia, and perhaps even under the amount that would result in a psychedelic experience. And in addition, the composition of the lozenges makes it difficult to dissolve them and inject them for another route of administration. So, and also the patients aren't able to get refills at a normal pharmacy of ketamine lozenges. It's kind of a specialty item. Another concern is tolerance to the medication. So typically with this kind of protocol, you might expect that over time you'd have to keep increasing the amount of ketamine that you take. But we actually took a look at the charts, and looking back over the patients, this was a very interesting thing to find, is that the amount of ketamine that they needed over time to reach that threshold actually decreased. And so the 3-month time point here is a time point that's 3 months following the beginning of therapy, which is a time point that generally everybody would have reached the max titration level. And then looking at a later endpoint, which for all of these patients was December 2015. And so most patients either stay the same or decreased in dose. So, that's helpful, especially when considering some of the potential but not proven side effects of ketamine, like cystitis. So the most common side effects of ketamine are lightheadedness, sedation, and moderate dissociative effects. Of course, it's arguable if that's a side effect at all or actually a helpful part of therapy. Less frequently were blood pressure changes, notably hypertension, nausea, and headache. And over the course of several years, and the group of patients that we looked at, there were no long-term negative health consequences that could be directly attributed to ketamine administration. So importantly, that means no hypertensive crises, no evidence of drug-seeking behavior, so patients weren't, coming in and trying to redose or calling up the pharmacy themselves. And importantly, there was no bladder damage. And I think this is due to a careful screening process that all the patients go through, and the low dose that was used of ketamine, and consistent monitoring of vitals and regular appointments with a physician. So the question remains, does this procedure work? And so what I looked at was the charts of the patients, and typically in these studies, you would look at validated psychiatric measures to find out if people were having relief from their depression. But in this case, they were only doing those measures upon intake, and so that posed a problem to me trying to arrive there from the outside and find out if depression treatment was really working. So we had to find another measure, and what we did was look back at the charts to see the number of days that patients were spending as an inpatient in a hospital. And in most of these patients' case, they weren't even spending, days in a hospital. These patients were spending weeks, sometimes months, as an inpatient in a hospital. And I think just that alone, that we could even consider using a measure like this is pretty telling on really the emergent need for more effective depression treatment. These patients were ones who had up to a dozen or more separate recognized treatments for depression, and nothing seems to work. So when we compiled that data set, what we found is that ketamine overall reduced the number of days spent as a hospital inpatient for psychiatric events. So what you have on the right is major depressive disorder patients without comorbid PTSD and major depressive disorder patients with PTSD. And on the left is a combined data set. And overall, we saw a 70% reduction in the number of days that patients spent as an inpatient in hospital. And that's pretty significant. So I didn't put any p-values up there or anything, but if you're interested, the p-value is less than 0.001, so highly significant finding. But the other thing that I have to point out is that clearly ketamine is not a magic bullet. Even after treatment, even after a 70% reduction, a lot of these patients are spending weeks and up to months in the hospital. And so, although this particular treatment method seems to provide relief to a large number of patients, there certainly, is more. There are more methods left to explore, and we haven't reached the end of the road by any means on finding effective treatments for treatment-resistant depression. So we saw similar reductions in hospital admissions, and again, in some cases we actually saw increases in the number of hospital admissions, but overall there was significant decreases. And I guess, maybe if this didn't quite make sense, each one of these lines is actually a person. And so if you take a minute to just think about, each of those persons' experiences, you really see how much of a difference this experimental treatment can make. So even though ketamine currently has this perhaps a Wild West reputation where, a vast number of people are trying a lot of different things, I really think we owe it to patients and to doctors and their families to continue to investigate ketamine treatment, maybe in large-scale studies, and to, at the very least, continue to allow this kind of treatment to happen, because it does provide people with significant relief from some of their symptoms. So just to recap, what we see is significant reductions in depressive symptoms. Often this relief is transient, often relapsing within days or weeks. Ketamine seems to be safe in measured doses in a controlled setting. And currently, and somewhat unfortunately, it's the only publicly available psychedelic therapy modality that's really available to the general public. Unless you're lucky enough to be able to get into a psilocybin study or lucky enough to be able to get into an MDMA study, really this is kind of what we're working with now. As was touched on in the panel earlier, there are wide variations in how to approach ketamine. This approach at this particular clinic is definitely sub-psychedelic, but patients still have changes in perception and visual changes, and really, I see those effects that they have psychologically, the overt psychotropic effects of ketamine to be kind of reinforcing to their therapy. At least that's kind of the feedback that they give me in their stories. And also ketamine, importantly, can be used alongside other treatment methods, including medication or therapeutic techniques. As I think Richard touched on earlier, there are a few drug interactions, but really not as many as you might think. As long as I have a platform to speak, I thought I would just mention something that's sort of been on my mind lately, and that is that psychedelic therapy in general has much more to offer contemporary Western medicine than simply the addition of novel psychoactive compounds. Psychedelic therapy really represents a practice dating back to at least the better part of a century and perhaps even longer. And as we move forward into this world where these medications become more disseminated in society and they become more integrated as part of a standard of care, and especially as they gain the interest of large healthcare organizations, I would say let's be careful to not lose the insights and the practices of the community and those who have worked alongside the compounds for decades to develop their best practices. This therapy happens to be, psychedelic therapy that is, more resource intensive than other approaches, and that's perhaps a necessary component. But that intensity provides patients with a deeper and more meaningful insight, and those experiences for them, I believe, are at the heart of the healing process. Thanks.
If you have any questions, you can come up and use this microphone. Please keep it concise.
Greetings. Thanks so much for talking, especially about something that those of us who are in the real world can actually perhaps go out and make use of. So much of this other stuff is very fascinating and in the future, but this is now. That's helpful. My question is about the mechanics of the delivery system. So I'm out in the real world. If I call my local compounding pharmacy and say, can you wrestle me up some lozenges with ketamine, what's the likely response? Do I have to go through some special contortions to get lozenges or have them made for me? And the other question is, how many milligrams of ketamine tends to be a good amount of ketamine to put in a lozenge?
The last question is pretty simple. So the lozenges are actually little squares that have sort of like prefab grooves in them, and each cube is 100 milligrams. And so patients can break that off and take it at increments of 25 milligrams. As far as the first thing goes, I would say the best thing to do at this point would be to look on. There are available websites that point you to the nearest ketamine practitioners, and those would probably be the best places to start. And as that map I showed at the beginning, if you're living in a large urban area, there's probably a good chance that there already is at least one ketamine practitioner in that region, and so that would probably be where I would start. I don't think it's probably a good idea to go out and look for it directly from a pharmacy. They probably push you away, but barring the access through an already established ketamine practitioner, if anybody actually knows a doctor or a psychiatrist who is curious and maybe more willing to try some things than others, perhaps introducing them to ketamine therapy and showing them some of the data that's come out within the last 5 years.
I want to be that psychiatrist, though.
Yeah.
Who do I approach to make lozenges?
Oh, great. Yeah, talk to me afterwards. Yeah. I don't do it myself. That wasn't an offer, personal offer. But yeah.
Hi, thanks for your talk. I'm curious how you approach concomitant personality disorder and if it seems to predict response.
I wish I could answer that question as well as I want to, but I'm not a practitioner myself, not yet, and so I think that would be better answered by maybe one of the people on the panel. Yeah, but I would be happy to find that out for you, in particular with oral ketamine. Yeah, thank you.
Hi, thank you very much. I think yesterday Dr. Sessa mentioned how I'm a psychiatrist, so oftentimes psychopharm is palliative care, and the MDMA, ayahuasca, psilocybin, one shot you could make a big difference and not have ongoing use. With ketamine, it feels more like ongoing use is necessary. You're not going deep and changing something. So,
well, having worked in a truly, more psychedelic therapy model when I was the study coordinator for Phil Wolfson and Ghislaine Andrews' study, I have seen the difference between those two approaches, and I might side on one personal favorite, I suppose. But right now, this is something that we do have available to work with. And of course, in this clinic where I'm, conducting research, it's not a psychedelic therapy modality per se. Some people have those effects from time to time at high doses, but in general, that's not the goal of therapy. The goal is really, to ease depression symptoms, and then, through the talk therapy work, try to reach people on another level. And I see patients enjoy it. They feel that it's the best treatment that they've had up to that point. And it keeps them out of hospital and keeps people from self-harm. So, if that can be, a bare standard, then I think it's worth exploring. But absolutely, there's a lot of different ways to approach things out there. Yeah, thanks.
Hi, I just want to say thanks for the talk. Just had a quick question, seeing how the different methods of administration are being explored with ketamine. We see the IV model and the oral model you're talking about, but there's also intranasal. I just want to know if you know anything about that in a therapeutic context and how that's...
Right. There's a couple things about intranasal. One is that it has a patent on it, and so it is at this point more expensive and less accessible than just classical RS ketamine. That particular formulation is only the S enantiomer, the S shape of the molecule. And there was a paper that came out in Nature last year that, in mice at least, they found that the R enantiomer actually happens to be more effective. So maybe they chose the wrong one, I don't know. But I can't really speak to that. I haven't seen it personally. But, it may very well work as another antidepressant. It seems that, whatever route of administration you have, at any variety of doses, there seem to be beneficial effects. And so I think, with the way things are going and with a lot of practitioners using and exploring different methods, hopefully they can get the information out there at gatherings like this or on the internet or however they want to, and really, maybe we'll come at a better idea of what best practices are. Thank you.
Thank you.
I was just wondering if you know of any studies that have compared the dosage to the antidepressant effect. Is there a direct correlation?
There have been studies to that. Yeah. So I guess one that pops off at the top of my head is a study that looked at they looked at a bunch of different measures, and they found that the one that had the strongest correlation with an antidepressant effect was actually the dissociation. And so that points to, higher doses, potentially directly leading to higher antidepressant effects. And it was funny also in that article, they called dissociation a side effect again. I guess, like Rich was saying earlier, there's still quite a bit of bias against dissociation and psychedelic tendencies in general, so, yeah.
Hi, I'm a registered nurse and I do IV sedation. And I work with low ketamine doses, the 0.5 mg per kg. I see that we use that in anesthesia. And I'm finding that a lot of psychiatrists that have ketamine clinics across the country are actually putting people in trance-like states and not sticking to the 0.5 mg per kg. And what are your thoughts on that? Like, what do you think about the low dose where you get into a very light sedation state versus a trance-like state?
I feel like that's a question better answered by an actual practitioner.
Yeah.
I think they'll definitely give you, a more detailed response on that.
Yeah, for sure.
Yeah, but, again, any number of doses or any level of dose, different routes of administrations, they all seem to have some beneficial effect. Yeah.
Okay.
Thanks.
Hi there.
Hey.
Thank you for your talk and for your work. I'm a lay person, and I don't know about research protocol and stuff. The word relapse struck me.
Oh, yeah.
And as I'm looking at the charts, it seems like you had pretty good, with the lines going, most of the lines were going down.
Yeah.
But there was a relapse within weeks to a month, which seems very quick to me. And I'm wondering about, is there any study going on or going to happen around repeated use of it? I mean, if I have a headache and I take X pill and it makes my headache go away, but then I get a headache in a couple of weeks, does that mean it didn't work? That I know it's not a parallel at all, but I'm just using it as...
Well, I mean, in this oral ketamine case, we are giving it over an extended period of time. Then I believe there have been IV studies done where they were trying to target that point at which people were starting to relapse. So being vigilant over the depressive symptoms of a patient. But again, actually, if we go back to that relapse study, so this one, again, this wasn't in our patients, this was at Mount Sinai, but what you see is a lot of people relapse, but also 30%, which is quite high, don't, at least in that time frame. So there's a wide variability there, and as far as like looking at the number of times you can administer it, I think it differs between patients quite extensively. Yeah.
As to whether it's okay to do that or not?
As to whether it's okay, it seems to be okay. We've done it before. Yeah. Yeah.
Okay.
But what doses are you talking about?
I don't know anything about doses as far as ketamine. I was just wondering if they relapse, well, if we give them more and it works, is there over time a cumulative effect where maybe
I see what you're saying. So it becomes
longer and longer period?
Yeah. Oh, I see. Okay. Sorry about that. Yeah. I don't know any studies to that effect, but again, there have been hundreds of studies published within the last few years, and so there might very well be something out there. Yeah.
We are at time, so thank you so much, John.